Okay, I'm Dr. Kodanda Swami, CR. I'm professor of pathology. So today I'm going to teach you about the routine things that you come across in your clinical practice. That is edema. Edema, it is defined as an abnormal excessive accumulation of the fluid in the interstitial tissue spaces. We call it as edema. That is, between one cell and the another cell, there is accumulation of excessive fluid, that is called edema. If the fluid accumulates within the cell sap of a single cell, that is called hydropic swelling. So now the fluid, if it accumulates in the abdominal cavity, that is called ascites. Then if the fluid accumulates in the pleural cavity between the parietal and the visceral pleura, if there is excessive accumulation of the fluid in the pleural cavity, that is called pleural effusion. And in the joints, there may be accumulation of the fluid, that is called synovial effusion. And in any road traffic accident, there will be accumulation of the fluid in the brain tissue, that is called cerebral edema. And due to this left ventricular failure or the left ventricular failure, there will be presence of fluid within the lung tissue, that is called pulmonary edema. So these are some of the examples of this edema. Before going into the details of this edema, our body is about 60% of our body weight is made out by the fluid. Remaining 1/3 is present outside the cells. Outside the cells. In this picture, I am going to show you that this is a blood vessel. And here the colloidal osmotic pressure influences the transmission of the fluid from the interstitial fluid into the intravascular compartment, whereas hydrostatic pressure moves the fluid from intravascular compartment to the extravascular compartment. So some amount of fluid gets accumulated outside the blood vessel during the continuous exchange of fluid from intravascular to extravascular and vice versa. This fluid will be drained by the lymphatics. Coming to the causes of edema. Coming to the causes, it is mainly, as I told, that increase in the hydrostatic pressure is one of the cause for the edema, and decrease in the colloid osmotic pressure is the second cause for this edema. And the third one, as I told, lymphatic obstruction, that is also one of the cause for this edema. Now, this whenever there is injury, there will be widening up of the gap between one endothelial and the another endothelial cell. This causes an increase in the vascular permeability, so that there will be fluid moves out from the intravascular compartment to extravascular compartment, resulting in the edema. That is the fourth cause. And the fifth cause is retention of sodium and water. In case of hypertension, if you excessive salt intake, resulting in the retention of sodium and water, thereby an increase in the volume overload in the blood vessels. This causes in turn hydrostatic pressure increase. Thus, there is edema, movement of fluid from intravascular to extravascular compartment, resulting in the edema. And then as we grow older and older, there will be loss of elastic tissue, this resulting in the decrease in the tissue tension, so which resulting in the edema. These are the probable causes for this the edema. Now coming to the increase in the hydrostatic pressure. What are all the causes for an increase in the hydrostatic pressure? Number one, impaired venous return. Impaired venous return, as we see in cases of this pregnancy, there will be pressure over the because of this pregnant uterus, there will be pressure over the pelvic veins. This causes the retention of the blood in the lower limbs. So there is no venous return, thus resulting in a rise in the hydrostatic pressure, resulting in the lower limb edema. You might have examined in your families, a pregnant lady will have lower limb edema. That is because of the external pressure, external pressure on the pelvic veins, thus resulting in an increase in the hydrostatic pressure, resulting in the lower limb edema. That is number one. Next, congestive cardiac failure. Once the heart fails to pump, then there will be decrease in the venous return. Once there is decrease in the venous return, automatically there will be decrease in the renal blood flow. That is, blood flow to the kidney decreases. So which in turn resulting in renin-angiotensin aldosterone mechanism. So this in turn resulting in the retention of sodium and water, thus resulting in the edema. That is one of the mechanism where we get the generalized edema in case of this congestive heart failure. Then the next one is constrictive pericarditis. This also there will be decrease in the loading up of the blood into the heart, thus resulting in decreased cardiac output, resulting in the edema. And then next one is cirrhosis of the liver. Cirrhosis, it is a one of the disorder of the liver where the liver will be converted into nodules. So once it converted into nodules, there will be raise in the pressure in the hepatic vessels. So this resulting in the raise in the hydrostatic pressure, resulting in accumulation of the fluid in the abdominal cavity, that is ascites. Then I told venous obstruction, that is in pregnancy and all those things, and thrombosis. What is thrombosis? It is a formation of an abnormal mass of clotted blood in the blood vessels. So once there is a formation of an abnormal mass of clotted blood, there also that resulting in obstruction to the flow of the blood, thus resulting in raise in the hydrostatic pressure, resulting in the edema. Next, in case of this comatose patients, or hospitalized patients, there is no movement, there is no ambulation, that is, movement is not seen. In those cases, the prolonged dependency, which resulting in a rise in the hydrostatic pressure, thus resulting in the edema. Then the next one, a decrease in the colloid osmotic pressure. What are all the causes for this decreased colloid osmotic pressure? So it is the albumin which is responsible for the colloid osmotic pressure. In case of this, the people that is one of the cause for this is glomerulus, that is nephrotic syndrome. That is a kidney diseases where there will be leaky glomeruli. So once there is leaky glomeruli, the protein escapes through the urine. So this resulting in a decrease in the albumin in the plasma. Once there is decrease in the osmotic pressure, which in turn is due to the decrease in the albumin, thus resulting in the edema. That is one of the cause. Then liver cirrhosis, the liver becomes non-functional. That is the factory where the metabolism of various lipids, carbohydrates and then protein occurs. Because of this cirrhosis, the liver doesn't function, so there will be decrease in the albumin. So this also causes the decrease in the colloid osmotic pressure, thus resulting in the edema. Malnutrition, when we were students, we used to come across this kwashiorkor and marasmus, where there will be proteins, the supply is less. So because we are underprivileged, low socioeconomic condition, there will be decrease in the supply of a protein. So this resulting in the protein energy malnutrition. That is one. Then there is one condition called protein losing enteropathy. Here, continuously there will be loss of protein, whatever the amount of protein that you supply to the patient, but still that in this condition, the protein is lost through the stools. So thus resulting in the decrease in the protein, thus resulting in a decrease in the colloid osmotic pressure, resulting in the edema. Then the next one cause is a lymphatic obstruction. What are all the causes for this lymphatic obstruction? One is the lymphangitis, that is inflammation of the lymphatics. Whenever there is inflammation of the lymphatics, automatically there will be obliteration of the lumen of these lymphatics, thus resulting in the lack of taking out of the fluid by this lymphatics. That is number one. And then in case of this cancerous condition, that is the tumor, in those cases the tumor cells aggregate together to form a mass called tumor emboli. So in that tumor emboli, there will be block in the lymphatics, so that it resulting in the edema. For example, in case of carcinoma of the breast, these cancer cells or the tumor cells obstruct the lumen of the lymphatics, thus resulting in the skin color changes, edema of the breast with skin color changes, that is called pudgy orange. PEU-DORANG. That is the skin alteration. That is one of the example for this neoplastic obstruction, the tumor cells obstruction in the lymphatics, thus resulting in the edema of the skin of the breast. Then the next one is the post-surgical. So whenever there is a surgery, for example, this carcinoma of the breast, they will do the surgery. During that time, there may be obstruction to the lymphatics resulting in the upper limb edema. That is a post-surgical. Then post-irradiation. Even in case of carcinoma of the breast, they will give this irradiation. Due to the irradiation, there will be obliteration of the lumen of this lymphatics, resulting in the edema of the upper limb. And some more causes for this lymphatic obstruction is filariasis. You might have seen in the coastal areas, the people with the big leg, that is called elephantiasis. Elephantiasis, that is due to the Ucheraria bankruptcy, filariasis. In case of filarial, dead bone obstructs the lumen of the lymphatics, resulting in the lower limb edema, which appears like an elephant. That's why it is called as elephantiasis. So these are the causes for this lymphatic obstruction, which resulting in the edema. Next is retention of sodium and water. Excessive in salt intake with renal insufficiency. Suppose the renal disorders, any renal disorders, if the patient takes some more amount of salt, then it results in the sodium retention, resulting in the water also retention, that is increased tubular absorption of the sodium, so which resulting in renal hypoperfusion, increased renin angiotensin aldosterone mechanism. Then there will be retention of the volume in the blood vessels, thus resulting in a raise in the hydrostatic pressure, thus resulting in the edema. Then inflammation, as I told in the beginning only, a sting bite. So whenever there is a sting bite, there will be acute inflammation and increase in the vascular permeability, resulting in the edema, but which is localized. And even in cases of chronic inflammation also, there is increased vascular permeability resulting in the edema. Then the next one, so as I told, in case of heart failure, that is cardiac edema, heart failure, what are all the things that is going to occur? First is decreased cardiac output. Next is decrease in the effective arterial blood volume. And then rise in the renin aldosterone mechanism, so which resulting in the increased absorption of the sodium, and then retention of sodium and water, increase in the plasma volume, then transudation, and then edema. That is one mechanism. Then in case of heart failure, there is a rise in the central venous pressure. You might have seen in your wards, persons with cardiac failure, there will be raise in the jugular veins pressure. So that is increase in the central venous pressure and increase in the capillary pressure, thus increased transudation, edema. That is the second mechanism where the heart failure resulting in the generalized edema. And then next, I told malnutrition can also causes a decrease in the plasma oncotic pressure, decrease in the blood volume, thus resulting in the ascites and other effusions. As we see in case of cardiac failure, the edema is dependent. That means it depends upon the position of the patient. If the patient is lying down, the edema is seen in the sacral region. If the patient is walking around, the edema is seen in the ankle region. This is the speciality of this cardiac edema, and these are the mechanisms which are involved in the cardiac edema, right? Then the next one is this one. Okay, then I told the tumor emboli, that there is one more condition called Milroy's disease in case of lymphatic obstruction. That is weakness of the valves of the lymphatics, which can resulting in the edema, right? Then now clinical aspects. What is anasarca? You might have come across in the pediatric age group or in the adults, full edema of the face, and then there is lower limb edema, and then accumulation of the fluid in the abdominal cavity, ascites. This is called generalized edema, or otherwise called as anasarca. So, edema is present throughout our body, that is called anasarca or the generalized edema. If it is confined to a local region, for example, in case of inflammation, localized inflammation resulting in edema specific to a particular site, that is called localized edema, localized edema. Then if you apply pressure over the edematous area, then it creates, due to the pressure, there creates a pitting, that is called pitting edema. Pitting edema. Most of the edemas are of pitting in nature, whereas some of the edema, for example, this hypothyroidism, that is a increase in the TSH level, and the alteration in T3, T4 will be normal, that is hypothyroidism. In case of hypothyroidism, it is non-pitting edema. Even if you apply pressure over the edematous area, there is no creation of the depression, that is called non-pitting edema, most characteristically seen in case of hypothyroidism. Then now we have to differentiate whether this edema is of inflammatory type or a non-inflammatory type. Usually it is usually if it is due to the inflammation, then that is called exudate. If the edema is due to the passive process like heart failure, congestive heart failure, or the renal edema, or cirrhosis of the liver, in these cases the fluid, we call it as a transudate. And what is the difference between transudate and the exudate? This is very important to know the etiology of the edema. Is it inflammation or a non-inflammatory causes? This can be asked as a 5 marks question in your theory paper. So, what is the difference? First is color. In case of the transudate, it is clear or yellow, whereas in case of exudate, it is turbid and yellowish in color. Then coming to the specific gravity of the transudate, it is less than 1.018. Whereas in case of exudate, it is more than 1.018. Why there is an increased specific gravity in the exudate? It is because of a more amount of cells that are present in the exudate when compared to the transudate. And then the next one, if you allow the fluid to stand for a while, that is around 20 minutes, in case of transudate, we don't find any coagulum. Whereas in case of exudate, definitely we find a coagulum. That is because of an increase in the amount of fibrinogen. In case of exudate, we get the coagulum. The next is number of cells. Usually in case of transudate, it is less than 100 cells per cubic millimeter. Whereas in case of exudate, it is more than 100 cells per cubic millimeter. So that means more number of cells are seen in the exudate because it's an active process. And it is because of an increased vascular permeability. No doubt the proteins and even the cells can also transfer from intravascular to extravascular compartment, resulting in the exudate. That is what's seen in case of the tuberculosis of the lung tissue. There will be formation of an exudate within the pleural cavity, that is called and even in cases of abscess of the lung also, it is empyema, that is collection of more amount of cells. Then the next one is cell type. What are all the cell types that we see? In case of an transudate, it is mainly the lymphocytes or the mesothelial cells. What are these mesothelial cells? They are nothing but the lining cells of the pleural cavity, pleura or the peritoneum. They will be denuded into the fluid. That is the lymphocytes and reactive mesothelial cells are seen in case of a transudate. But in case of the exudate, it varies depending upon the etiology. If it is bacterial effusion, we see more number of neutrophils. And if it is tuberculous effusion, more number of lymphocytes. And if it is due to the cancerous condition, malignancy, then we see more number of malignant cells, cancerous cells in the fluid. Then coming to the LDH, that is lactic dehydrogenase. Lactic dehydrogenase in case of a transudate is normal. Because in case of exudate, there will be more number of cells. Once they disintegrate, so automatically we see more amount of this lactic dehydrogenase in the exudate. Then ADA, that is adenosine deaminase. ADA, It is important to know whether the patient has got tuberculosis. ADA level is high in case of exudate, it suggests it is tuberculosis, but it is normal in case of a transudate. So nowadays this ADA, some people, some clinicians are asking, some clinicians do not want that. Okay, that is about the now coming to the some of the specific edemas, pulmonary edema. This can be asked as a short note question in your theory paper. What is this pulmonary edema? That is edema present within the lung tissue, we call it as pulmonary edema. What are the causes for this pulmonary edema? It is mainly the left ventricular failure. Left ventricular failure or sometimes congestive cardiac failure. Mainly it is left ventricular failure which is responsible for the pulmonary edema, that is mainly due to the mitral stenosis and mitral regurgitation. Once there is mitral regurgitation or mitral stenosis, that is narrowing up of the valves of the left side valves, that is which resulting in the damming up of the blood in the pleural circulation, that is the vasculature of the lung tissue. So once there is damming up of the blood in the vasculature of the lung, then a raise in the hydrostatic pressure in the vasculature of the lung tissue. So this resulting in transduction of fluid from intravascular to extravascular compartment, resulting in the edema of the lung tissue. Edema of the lung tissue. What is the clinical consequences of this edema of the lung tissue? Suddenly the patient gets, early morning he will be sleeping, suddenly he gets up and go near the window, he will take respiration. That is the clinical typical feature that we see in case of pulmonary edema. Pulmonary edema. Then coming to the microscopy, and before microscopy, the gross pathology. Grossly, the lung tissue size is increased. Weight of the lung is also increased. They are boggy in nature, and we see the rib markings on the surface of those lung tissue. And if you cut open the lung tissue, we see the serosanguinous fluid or the frothy fluid on the surface of the cut surface of the lung tissue, and that is the gross pathology. Microscopically, we see these are the alveoli. So within the lumen of the alveoli, we are seeing the fluid, and between the alveoli, there are congested blood vessels, and some RBCs are also seen. This is a schematic diagram of this pulmonary edema, and that black color pigment is an anthracotic pigment, and this is what we have taken from the histopathological section of this lung tissue. This is pulmonary edema, which is a short note question, and it is due to the mitral stenosis and mitral regurgitation. But nowadays this because of this penicillin, invent of penicillin, that rheumatic fever is less common. That's why we don't come across this mitral stenosis and aortic stenosis. Coming to the next one, that is cerebral edema, that is edema of the brain. Edema of the brain. What are the causes of this cerebral edema? One is alteration in the blood-brain barrier. Alteration in the blood-brain barrier, and whenever there is a hemorrhage within the brain tissue, as we see in case of road traffic accidents, there will be hemorrhage within the brain tissue. And even in case of one of the disease called the aneurysm of the basal blood vessels of the base of the brain. So once it ruptures, there will be extravasation, blood is present within the brain tissue, resulting in the edema of the brain. That is the second one. Then concussions. So once you will be traveling in the bus, suddenly the driver applies brake, then your head hits the steel rod and goes back. That is called concussions. So in that concussions also the edema can occur. And then next one is space occupying lesions. For example, the tumors of the brain, any cancerous or any tumors of the brain, this also resulting in the edema of the brain. Then in cases of this infections, maybe tubercular meningitis or bacterial meningitis or viral meningitis, it resulting in edema of the brain. So these are some, and encephalitis. These are the some of the causes for the cerebral edema. Coming to the what is the gross pathology of the edema of the brain? Grossly, there will be increase in the size of the brain, an increase in the size of the brain, and it is soft in consistency. soft in consistency, and the gyri, there is flattening up of the gyri. There is flattening up of the gyri and narrowing up of the sulci, narrowing up of the sulci and flattening up of the gyri, very characteristically seen in case of this edema of the brain. Coming to the next one, that is microscopy. Microscopically, there will be eosinophilic material seen in between the cells, and this brain has got blood vessels. Around the blood vessels, there is a space called Virchow-Robinson space. Because of this edema, there will be widening up of this Virchow-Robinson space. And the third one, at some areas of hemorrhage can also be seen. Why death occurs suddenly in case of road traffic accidents? There are in cases of edema of the brain, because once there is edema, there will be increase in the size of the brain. It cannot go beyond the skull. In the base of the skull, there is called foramen magnum. So once the brain herniates into the foramen magnum, there will be pressure over the important centers that is present in the base of the brain, resulting in the sudden death of the individual. That is, vital centers are compressed, no? So once the vital centers are compressed, naturally the patient dies off. That is one of the clinical emergencies that we come across in case of the edema, right? That is brain edema. Convulsions, those are the things that I have told, right? Then that is about the general aspects of this edema. So coming to the next one, what is hemorrhage? What is hemorrhage? Hemorrhage is nothing but the extravasation of the blood. So presence of blood outside the blood vessels, we call it as a hemorrhage. Maybe any rupture of the blood vessels, it can resulting in the hemorrhage. If there is accumulation of the blood anywhere in the tissue, that is called hematoma. For example, in case of there is one condition called hemophilia, that is factor 8 deficiency. In that case, because of this hemorrhage, the blood collects in the joint cavity, that is called hematoma. And in cases of this leukemia and all, that is blood cancer, there will be decrease in the number of platelets. So once there is decrease in the number of platelets, it resulting in small, tiny red dot-like structures, that is called petechiae, which will measure 1 to 2 millimeters, 1 to 2 millimeter. If it is larger than 1 to 2 millimeter or more than 3 millimeter, that is called purpura. And if it is 1 to 2 centimeters, very large in size, that is called ecchymosis. And then if there is a hemorrhage present within the abdominal cavity, that is called hemoperitoneum. This is especially seen in cases of malignancy, that is cancer condition of the gastrointestinal tract. And if there is a rupture of the heart, then there will be collection of the blood around the heart, that is the parietal pericardium and visceral pericardium, that is called hemocardium. And sometimes there may be collection of the fluid in the pleural cavity, that is called hemothorax. And as I told, in the joint, if there is collection of the blood, that is called hemarthrosis, right? And next, what is hyperemia? What is hyperemia? Hyperemia is damming up of the blood in the arterial circulation, dilated arteries and arterioles. Suppose in the morning, if you do the exercise, you feel heat in the calf muscles. That is because of the dilated arteries. There will be flushing up of the blood into the dilated arteries and arterioles. That is called hyperemia. One more example, this females, once they shy, there will be blushing up of the blood into the face. So that is also one of the example for hyperemia. What is the cause for this hyperemia? It is the neurohumoral mechanisms. So where there will be dilatation of the blood vessels, arteries and arterioles, and flushing up of the blood in the dilated arteries and arterioles, that is called hyperemia, right? And whereas the other one is congestion. So let me, before that, congestion, that is in case of the systemic diseases, there will be flushing up of the blood in the dilated veins and venules. Dilated veins and venules, that is called congestion, which is a passive phenomena. Hyperemia is an active phenomenon. So, I think in the next class, let me tell you about the congestion, that is CBC, liver, lung, and liver, lung, and then the spleen. So, which can be asked as a short note question, that I will continue in the next class. Thank you.